So hello everyone, my name is منار العتيبي and today I'm going to present a lecture about psoriasis and papulosquamous diseases. So today we're going to cover psoriasis, lichen planus, as well as psoriasis rosea. So first for psoriasis, it is an immune-mediated chronic inflammatory disease in which both genetic and environmental factors play a critical role. So it is multifactorial. It is the most common papulosquamous disease and characterized by the development of red, silver scaly, sharply demarcated plaques. They're usually on the extensor surfaces. The common sites include scalp, elbows and knees, as well as nails, hands, feet, and trunk. The epidemiology, it has a bimodal onset at 20 to 30 years of age, as well as 50 to 60 years of age. It affects about 2% of the population. For the etiology, as I said, it is multifactorial. So the genetics and environmental factors will interact together to cause the disease. The environmental factors include infections such as streptococcal infections and HIV. The medications include interferons, beta blockers, lithium, and the rapid withdrawal of corticosteroids. The other thing is the Kopner phenomena, which is where when you traumatize or there's trauma to the skin, it can cause the elicitation of the psoriatic lesions, which can be seen in the picture. And this Kopner phenomena can be seen in psoriatic patients. So for the clinical variants, the psoriasis includes chronic plaque psoriasis, which is also called psoriasis vulgaris, as well as gutted psoriasis, pustular psoriasis, inverse psoriasis, erythrodermic, and linear psoriasis. So for the chronic plaque psoriasis, the typical lesion will be well-demarcated erythematous plaque with silvery scale. The silver scales are specific for psoriasis, and it often presents as symmetrical lesions on both elbows, knees, scalp, perisacrum, hands, feet, intergluteal folds, and umbilicus. The lesions can be surrounded by a peripheral blanching ring, as you can see in the picture. It is called a Warnoff ring, and this is also specific for psoriasis. So up until now, we said that silver scaling and Warnoff rings are specific for psoriasis. These are two signs that are specific. Now, as you can see in the picture, these are all pictures of psoriasis. As you can see, there is a well-demarcated erythematous plaque with silver scaling. If you remove the scale, there will be pinpoint bleeding. This is called the Uspid sign, and this is also specific for psoriasis. Now, the gutted psoriasis, it is generalized in distribution. There will be small papules or plaques with adherent scale. It affects children more than adults and is often preceded by an upper respiratory tract infection, mostly streptococcus infection. So you have to ask about it in the history. For pustular psoriasis, there will be erythema with sterile pustules arising within this erythematous painful skin, as you can see in the picture. They're often associated with fever. They can be generalized or localized. And as for the triggers, it can be triggered by pregnancy, hypocalcemia, rapid withdrawal of corticosteroids, as well as infections. Now for inverse psoriasis, hence the name, it presents with shiny pink well-demarcated thin plaques with minimal scales. That's because it is formed in the folds area, such as the axilla, inframammary folds, intergluteal clefts, retroauricular folds, as well as the inguinal creases. That's why it has only minimal scaling, as you can see in the picture. For erythrodermic psoriasis, there will be generalized erythema of the skin with areas of scaling. It can start gradually or acutely, and there are some hints that can guide you to the diagnosis, as finding some nail changes, facial sparing, as well as the typical plaque type psoriasis in the history and in the examination. And it can be seen after the abrupt withdrawal of corticosteroids as well. Lastly is the linear psoriasis. It is characterized by the linear distribution of the psoriatic lesion along the Blaschko lines. These are the lines of normal cell development in the skin, as you can see in the picture below. That's where the linear psoriasis develops. Now, psoriasis can also present in nails, where we call it nail psoriasis. It presents more in the fingernails more than the toenails, and it is more associated with psoriatic arthritis and the severe form of cutaneous psoriasis. The findings include nail pitting, oil spots, where there is separation of the nail bit from the nail plate, and this is a specific sign for the nail psoriasis, while the nail pitting is the most common. As you can see in the picture, there are pinpoint dots in the nail, and these are the nail pitting. Other signs include onycholysis, splinter hemorrhage, as well as subungual debris, where there's like keratin accumulation in the or beneath the nail. Now for psoriatic arthritis, it develops in about 5 to 30% of patients with cutaneous psoriasis, where the patient will have joint pain and inflammation. It is mostly seen in patients with moderate to severe cutaneous psoriasis, as well as those with nail involvement. It mostly presents with asymmetric oligoarthritis affecting the distal interphalangeal joints. Now, for the diagnosis of psoriasis, it is typically a clinical diagnosis, but if you're not sure, you can use biopsy for the confirmation or use it for medical legal reasons to start immune suppressive if you're going to use it. For the treatment, we can use topical agents if the psoriasis is localized. The first line is topical corticosteroids because we never use oral ones. As I said, the oral ones can trigger the development of psoriasis. So we use topical ones only. And we can also use the vitamin D3 analog. Second line include calcineurin inhibitors, and they can be the first line in the sensitive areas. You can also use TARS, anthraline, tazobactam, and for the last two, anthraline and tazobactam, they will cause inflammation. This will direct the immune system towards this inflammation, which will make it occupied by this inflammation rather than itself. And lastly, you can use the intense pulsed light therapy at the localized lesion. You can also use phototherapy and systemic agents for generalized disease, such as phototherapy, which is one of the first lines, as well as the oral retinoids and methotrexate. The second line include targeted immune modulators, such as tumor necrotic factor inhibitors or antagonists. These are more directed, have less side effects, as well as the cyclosporins. Now moving for the Lichen planus, it is an idiopathic disorder that can affect the skin, hair, nails, mucosa, and is most commonly affecting the adults. It presents with 6 P's, as they say, purple, polygonal, papules or plaques, with pruritus that can present with post-inflammatory hyperpigmentation. As you can see in the picture, you can see there are papules and plaques that are violaceous in color. There is post-inflammatory hyperpigmentation as well. For the etiology, it is mostly idiopathic, but it can be triggered by some drugs such as beta blockers, anti-malaria, thiazide, furosemide, spironolactone, and lithium, as well as the exposure to some metals such as mercury and gold. Another trigger is the dental restorative material, and if you find the patient having these, you might ask the patient to change it. And lastly, the hepatitis C virus, and this is more commonly with the oral lichen planus. Okay, for the clinical findings, as I said, the 6 P's, as well as a characteristic finding, which is called the Wickham's striae. This is a network of fine white lines on the surface of papules and plaques, as you can see in the pictures. The most common sites include the scalp, flexor vests, forearms, genitalia, distal lower extremities, and perisacral areas. Now, for the variants of lichen planus, there are many variants, but we're going to discuss the most significant ones. So the first one is the acute xanthomatous or eruptive lichen planus, which is the most common variant. It starts abruptly and has a widespread distribution. Then there is the annular lichen planus, which forms thin raised border with a hyperpigmented or skin-colored center. It usually is in the axilla or groin. And then there is the hypertrophic lichen planus, which is usually on the shins and mostly in black males, and these patients can develop squamous cell carcinoma. Other variants include lichen planopilaris, and these patient will present to you with scarring alopecia, mostly in the scalp, because there will be keratotic plaques within the hair follicles, and if you examine these patients, you'll find that there's a surrounding red to violet colored rim around these hair follicles, causing this scarring alopecia. Another variant is the nail lichen planus. As you can see in the picture, there's the lateral thinning and loss of the nail plate. There are also fissuring. There's also something called the dorsal trigoid. In this, there will be the overgrowth of the proximal nail fold into the nail bed, as you can see in the picture B. And then we have the oral lichen planus. There are two forms of it, reticular and erosive. The reticular is the most common one, where you can see here in the picture, there's white, and picture A, white lacy or circular white lines on the buccal mucosa with small projections, and this is for the reticular type. As for the erosive type, you can see in the right picture there are erosions and there are some scarring. For the diagnosis, the same like psoriasis, it is clinical, and then if you are in doubt, you can use biopsy to confirm. For the treatment, you have to stop the offending agent if it is found. So if the patient has hepatitis C virus, treat the patient. If the patient used dental restorative material, then ask the patient to change it. You'll also ask the patient to moisturize, and then we can also use topical corticosteroids or calcineurin inhibitors, as well as phototherapy. If the disease is severe, we can use systemic therapy such as oral corticosteroids, hydroxychloroquine, and systemic retinoids, especially in hypertrophic lichen planus. Lastly, we're going to discuss Psoriasis rosea. It is defined as an acute self-limiting papulosquamous inflammatory disease characterized by multiple erythematous, scaly patches over the back and trunk and along the cleavage lines. The etiology is unknown, but it is thought that the viral agent, the human herpes virus 7, is implicated. It usually affects the young adults and is mostly seen in spring and fall. For the clinical features, it usually presents as a large patch on the trunk called the herald patch, which is the largest one. Then it develops into small salmon-colored papules and plaques that distributes in a Christmas tree pattern. They also have these scales at each lesion. The scales are at the periphery of the lesion and free from the center, which what we call the marginal collarette scales. For the diagnosis, same as the previous one, it is clinical and it is confirmed by biopsy. For the treatment, as I said earlier, it is self-limited. So if it's mild, you can reassure the patient. If the patient is concerned or if it's more severe, then we can use topical or systemic steroids. We can also use oral antihistamine for the itchiness. We can use UVB light and systemic antibiotics such as erythromycin and azithromycin because of the inflammation. And lastly, we can use acyclovars because, as we said, it is thought that the human herpes 7 virus is implicated, so we can use antivirals such as acyclovir. This is the end of the lecture. Hope that everything is clear for you now. And if you have any question, please do not hesitate to write it in the comments below, and I'll try to answer as soon as possible.